Hi everyone, this is Neel Raithatha, consultant, audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral, fully occluding, really soft, mushy wax that's enveloped, at least in their right ear, by a thick layer of glossy skin, and that will reveal itself in a moment. Now, because the wax is so soft and mushy, it's very difficult to perform microsuction. Their soft wax tends to block the inside of the suction probe, which then of course reduces suction power. So I've gone in with some medical grade olive oil spray, and what the medical grade olive oil spray tends to do is to bind and coagulate this wax. It just makes it a bit easier to suction. It also lubricates the inside of the suction probe to minimize blockages. Now you can see this thick layer of glossy skin to the right hand side of the ear canal, so that part's just come away. Now the consistency of this wax I would grade as a grade 6. A while back, when I was developing my clearwax theoretical training course, I decided to modify the Bristol stool chart into a modified Bristol Cerumen chart, and similar to the stool chart, I graded the wax in different 7 different consistencies, with grade 1 being rock solid, dry, crusted wax and dead skin, and grade 6 being almost liquid molten type of wax. So I would classify this as a grade 6, maybe grade 5/6. So it's almost got this soft stool consistency, and again, it can make it very difficult to suction. So I've just put some more oil in. You can see it's slightly blurry, so I'm just going to suction some of the excess oil. Now, using a curette is an option, but we are going quite deep in the ear canal, and sometimes with a curette with this consistency of earwax, it almost smears and smudges the wax up against the canal wall. It's almost like when you're spreading some jam or butter on your slice of toast for breakfast in the morning. So I'm just persevering with suction here, and we're doing it by layers. So I'm instilling some medical grade olive oil spray. That's coagulating and binding the surface of the wax. Once I've removed that, I'm going back in with some more oil. Again, you can see some skin there that's enveloped the wax plug. Now it'll become apparent once I remove the plug, but this patient's got quite a prominent inferior recess. And what I mean by that is that our ear canals, as we approach the eardrum, they actually narrow. They narrow typically at the floor of the ear canal, and also the front part of the ear canal, the anterior canal wall. And this occurs about 1/2 centimetre or so away from the eardrum. And then the ear canal in those 2 regions widen again, and it leaves behind 2 recesses: an inferior recess, which is like a trench or a basin at the floor of the ear canal adjacent to the eardrum, and an anterior recess, or a widening of the ear canal just in front of the eardrum on the front wall. So in the case of the right side, it will be the right hand side of the ear canal. Now the eardrum is now partially visible, so this patient can already hear significantly better, but we want to see if we can remove the majority of this wax that's remaining, so we can also visualize the eardrum in full. So you can see that some of that oil's still there. We've got some glossy skin, so this has got a bit blurry, so I'm just going to come away, suction some of the excess. Quite often when you put olive oil drops in the ear, it lines the cilia, the hairs at the entrance of the first bend. So I'm just mopping that up. So again, it's just a bit too blurry, so just coming away, just give it, I think I may have even got a bit of cotton wool just to wipe the hairs at the entrance there. So going back in, again, it's just got slightly blurry. So one of probably the negatives of an endoscope is when you do apply olive oil and you're suctioning, you can get a bit of blurry. So that can also happen when you're using a microscope or the wax scope, for example. But the lens with the microscope and wax scope is not internal. So an endoscope, hence the name, the lens, the magnifying lens, is within the internal orifice, so in this case the ear canal, but you can work around that. So I'm using the fine end suction probe because we're going quite close to the canal walls here. Now there's going to be a bit of residual wax skin remaining, but I'm happy with with the amount I've got away. So we can see the eardrum. The bottom part of the eardrum is very difficult to visualize, and that's because, as mentioned, this patient's ear canal, as we approach the eardrum, it narrows and then it widens again, and that creates this trench. So we're going to hopefully have a look at the eardrum. I'm going to position the endoscope so we can look down into the inferior recess. So I'm happy with that. There is a bit of residual wax around the edge, but it's non-significant, and you can see by angling the endoscope downwards into the trench, we can visualize the bottom section of the eardrum, so the southern hemisphere. Moving on to the left side now, this left ear was extremely bendy, and as you enter the ear canal has got quite a steep slope upwards. Most of our ear canals do. I think the average inclination is around 32 degrees, but of course you can get individual differences, not only between individuals but between ears. Now guys, I must apologize. In my last video, I forgot what number it was, but I gave the name part 1 because I was going to upload the patient's right ear subsequently, but unfortunately I accidentally deleted the video. I was running short of memory on my devices, and I don't know how it happened because I was consciously telling myself make sure I don't delete that particular video, but unfortunately I did. I was unable to retrieve it because also with the iPhones you delete a video or an image and it goes into your bin, and then you have to empty your bin. So when I couldn't find it, I was hoping that it will still be in my bin, but unfortunately I also deleted it from there. So I do apologize, but you did get to see that plug as the thumbnail that I removed. To be honest, the video itself wasn't as enticing as the video I uploaded. So you can probably see now how bendy this patient's ear canal is. I'm looking straight into the ear canal, but the eardrum veers off to the left, so I'm just mopping up near the entrance. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.